and everyone else can catch up. Thank you all for joining us this afternoon. This is Lynette Elliott. This is our June 20th Gravity Project meeting, and I will apologize for the date typo in yesterday's email. That was my fault, and I'm sorry if something got lost in translation. We appreciate all of you being on the call today. Just as a reminder, we have everyone on mute as they call in. So during the presentation, if you would like to pose questions or comments, you can use the chat feature in your WebEx meeting. And please send it to everyone so that both Evelyn and I and others can see it and address your comments while we move through the presentation. If you have any technical difficulties, you can feel free to email me directly, lynette.elliott@emiadvisors.net. Hopefully we've gotten all of those niggling issues sorted out over these weeks. And thank you all for your patience and your ongoing participation. If you have not already done so, please do join the project on the wiki. This is the list that we are using to send out information on homework, meeting updates, etc. So if you are not receiving regular emails from us, it's probably because you have not joined the project. So please do so. You can join as an other interested party or as a committed member, whichever your schedule allows you to do. We have all levels of participants, and we appreciate you all. If you need to check whether you've signed up or not, there is a link in this presentation to check that on the wiki. And then other Gravity Project information is also available on the wiki, and we do include links in our follow-up emails so you don't have to try to frantically scramble to write all of this down. Next slide, please. Today we will be reviewing the updated schedule. Because we canceled last week's meeting, we have consolidated a few things and moved a few things around in our calendar. And then Evelyn Gallego will take you through the working draft use cases, the use case elements, and the actor transaction diagram. And then what we're going to do is open up the call as a working session. So you all will be taken off mute, and we will ask you all to remute yourselves if you're not speaking at the time. But we're hoping for an open discussion on use cases 1 through 3 today. And then we will cover next steps at the end of the call like we usually do, and we will set you all free in an hour. Next slide, please. I will hand it over to Evelyn right now to cover the calendar.
Thank you, Lynette. Can you hear me good?
Yes.
All right. So thank you, and good afternoon. Good afternoon, everyone. Great to see such a turnout. I know it's the end of June, and many of us have started our vacation schedule, so we really appreciate you joining us today. So I'd like to pause and revisit our schedule, especially for those that are tracking our progress to date. We are now at week 8. And of course, thank you to those who have joined us from the start, and welcome to those joining us for the first time today. We appreciate you. So as Lynette mentioned, we did cancel last week's meeting to allow the internal project team more time to work on the use cases and consolidate public input. We made slight adjustments to the meeting tasks and homework on our schedule to enable us to still meet our target timeline for completing the use case package and kicking off the food insecurity domain work group by July 18th. So as a result, we will be publishing a full use case document for review now on July 5th. I know it's the day after a national holiday, but we want to ensure that we are able to give you something that you can review as a collaborative and provide us input on, and then of course vote on it. So, and we'll publish a final document, I guess, for committed members to vote on the week of July 18th. But as a reminder, only committed members can vote in the consensus voting period, but anyone can participate and submit comments as part of the end-to-end review cycle, as well as our weekly homework. We're inviting anyone to submit their thoughts. On July 11th, we will also use part of our meeting to introduce a new data element submission web tool we recently created to streamline our data element submission process. So right now we're asking you to send us your data elements using the data element spreadsheet that is on our Confluence site. So that means you have to download it, enter the data elements you're using by activity, and then email it to us. So very exciting. Stay tuned. June 11th, we will show you a new web tool that will allow you to streamline that process and also help us in the review of your submissions. Just quickly, here's a snapshot of our schedule for the next month and August. Our final use case now is scheduled for August 1st. So we'll start what you see here, week 14th is when we'll start, conduct final use cases. And again, we also want to allow our team time to consolidate any feedback and votes and present dispositions back to the community. We are still on point to complete the food insecurity data set review within a 6-week window. So for those joining us for the first time, we have scheduled the 3 domains. We will review data sets on a 6-week cycle to allow us to be completed with this work with the review of the 3 domains, food insecurity, housing instability, and transportation by October, and allow us time to develop a recommendations report and then streamline our process to move on to phase 2. So end-to-end review of the food insecurity data sets and value set gaps is scheduled for August 22nd, and we anticipate kicking off the next domain work group, housing instability, on August 29th. So before we start our working session for today, I just want to, again, thank everyone who has taken the time to submit their comments and revisions for the patient story 1, Rebecca Smith. So we've talked about Rebecca for a while, for the last 3-4 weeks. We also introduced a use case 1. So as a recap, we have identified 3 use cases to visualize the actor and system transactions described as a narrative in patient story 1. So these 3 use cases were developed to exist. Again, we had talked about this initially. We want these to exist as standalone regardless of the patient story. We had shared that we have received other patient stories from collaborative members. We also acknowledge that the American Medical Association is working on another patient story as well. And we want to be able to have these 3 use cases reflect transactions that also exist in those. So again, as a recap for those joining us for the first time and haven't had a chance to look at our existing documents, use case 1 is relevant to how coded social determinants of health data is captured or are captured in a health system and how data are shared with other systems. Social determinants of health data are documented either as part of a screening or assessment or diagnosis activity and may be the reason for ordering care activity. So this use case is really about the initial transactions involved in documenting SDH data. Use case 2 then is focused on taking actions in response to the data collected about social risks in an electronic system. Actions can include counseling, education, consults, referrals, case management, care planning, and modifications to treatment. So lots of actions. Of course, when we get into the use case, we are focused on those value add transactions, really system to system. Like there's ones where if we have data moving or data exposed from one system to another, those are the ones we want to hone in on. And then our last use case builds on the previous 2 and involves the gathering and aggregation of data for use in upstream or downstream activities such as population health management, quality reporting, and risk adjustment or risk stratification. Let me just move forward. All right, so during our last sessions, I introduced all these concepts. Of course, you saw them in various versions, and their relevance to creating a use case. When we talk about assumptions, initially we talked about assumptions in terms of those that are relevant for the patient story. Really important because we are making lots of assumptions. Again, given our scope of work, we are focused on data elements, coded data elements. So we are incorporating many assumptions into the story because we're not going to do a deeper dive on any other transactions. But we also want to recognize that we have specific assumptions based on the use case. Preconditions refer to what must be in place from a systems perspective to support interoperable data sharing, and post-conditions describe the state of the system that will result after the execution of a process activity. Transactions, we introduce them again. We'll spend more time going through these as examples in our use case, but just a recap of what these terms mean. Transactions are the actual exchange between the two systems and the message content or payload. So we appreciate that some of these terms may not be common to many of you. So we want to, when we talk about message content or payload, that's really actually the data itself that gets moved. And so that, for us, is very relevant to the SDH data sets we're identifying. I also talked during our last meeting about 3 primary actors: the human actors, which we also emphasize through our personas, the business actor, and the system actor. Business actor being more of an entity, an organization. Oh, I'm hearing an echo. Is someone on mute? Okay. So when I walk through the use case document, you will note that these actors are now described in terms of their technical roles. Oh, I'm hearing some background noise. Is someone unmute? Not unmute? Okay.
This is Lynette. I just muted everyone.
All right, thank you. All right, so just back to the technical role. These roles indicate the relationship between the sender and the receiver of data. So in our case, we have actors that serve as the requester, meaning they are asking for information from another actor, and this receiver of information then acts as the request recipient. So that's what you see here under roles, that we have this relationship between the actors identified. You also have an order placer and an order filler. You have an information source interacting with an information recipient. And then again, based on our use case, we also have a data aggregator role that interacts with an information recipient. So again, these will make more sense when we go through the Word document with the descriptions of the use cases. Finally, after transaction diagram, we're going to spend some time going through all of this. So this is just the general one that shows all these elements coming together. So you'll see, same business actor, human actor, system actor, and then the role, and then the types of transactions. So we have numbers, we have direction of data flow, and of course, most important, so you'll hear me emphasize this often, our scope of work is really to define these information payloads or these message content. What are they? What do they need to be? And as we go through food insecurity, housing instability, and transportation, that's what we would be incorporated here based on question answers being asked, diagnoses, planning activities, and then treatments or interventions identified. All right, so before, I'm going to pause now and ask Lynette to kindly unmute everyone while I change into the Word document, but want to make sure if you do have any questions, please bring them up as I share Word.
And I apologize, I'm going to have to ask everyone on this call to please mute your own device. Your phone, or you can click on the little microphone icon that's next to your name in the attendance list. And we are getting a lot of background noise, so somebody's probably driving.
Hi, someone is not. Please mute your sound. Can you see who it is, Lynette?
I'm looking. Yep. Okay.
Got it?
I think I got it. All right.
Okay. Any questions before I dive into updates on the use cases? All right. Okay. I will take that as a no, but again, a reminder to everyone, this is our open working session now. We've quickly gone through our updates because we have a lot to cover today and we really need your input. And I know we're moving really quickly through our use case development process, but it is for a reason. We want to have the baseline ready, these transactions defined, and of course the opportunity of where the payload would be identified and further defined so that, again, we could quickly move on to our domain work groups. All right, well, if you're still gathering your questions, I'm going to just, so what I'm showing here is the Word document. This is what is available on our Confluence site. What we sent out yesterday as a update for this meeting, it is a consolidation, again, thanking everyone who has submitted their comments. This version I'll be sharing now actually does incorporate some comments we received today. So again, appreciate, and we're working really quickly to be able to incorporate all your feedback. So again, we want to spend most of our time today going through the use case elements and actor transaction diagrams, but I do want to highlight changes to the patient story. So we heard you loud and clear during our last meeting that, especially as we spend time going through use case 1, that we really need to look at or identify value add transactions. This patient story has many transactions. And of course, we can't work on every single one. We really need to look at ones that are, again, going to add value, that really demonstrate the robust capabilities that health IT systems can demonstrate and are demonstrating now, and then define those accordingly. So as a result, again, based on all your feedback, we have made slight modifications to patient story, where Rebecca, initially we had her go into the primary care, for her annual wellness visit, and then having her complete screening, social risk screening questionnaire using a mobile tablet provided by the practice, right? So they handed it over to her, the clinical staff member, and she answered the questions. So part of the thought was, having that be sent to the EHR. So upon reviewing it, and feedback was, what about, if she had it on her own device, right? And the ability, again, to have data move from one system to another. So in this case, we have slightly modified the story to have Rebecca receive, she's, like we all do when we have an annual wellness visit, we get a reminder, email, text message, or call, to confirm the meeting. And in this case, she will, she receives that and gets the opportunity to update her communication options. So that's, again, I'm just summarizing it here. She is able to provide her Gmail account because our patient story and our assumptions reflect that she does have access to a mobile phone, has access to text messaging and Gmail and email. In this case, we're being specific, but of course we could call it any account. And then, she acknowledges that she would like to receive, information electronically. So she's also, through this process, informed about this screening questionnaire and is given the option of either completing it through the patient portal or through a mobile app, or when she comes into the office. For our patient story, she agrees to complete it when she comes into the visit. So when she goes to see her physician and arrives, that's when she's being checked in, that someone walks her through being able to download the app and then complete the questionnaire there. Of course, many assumptions. Some of the feedback we also got from you is that these are services that most of practices are not able to provide now. But again, we want to be able to highlight the opportunity, the robustness of health IT systems now, and that they can support this. So it's really, what can we do to define that? But our use cases also reflect alternative flows. So we do have the case where Rebecca, in our story, may decline to complete something. She may, want to complete it using a paper-based form. In that case, that paper-based form will be scanned and updated into the EHR. And I do have some questions regarding that. And then, yes, of course, there was more updates. So again, I don't want to spend our time going through. Again, I welcome you to revisit the patient story. Make sure your comments are on it. I know we received lots from the community, so want to make sure it's reflected to have a very concise story. Okay, and before, actually, I do see a question. So, Jim Myers, as I see this screening deployed in the safety net, I find that the provider does not go over each social risk screening response. Dr. Sanchez uses her EHR to review the social risk screening responses. I suggest the sentence, okay. So Jim has recommended we say Dr. Sanchez uses her EHR to review the social risk screening results. Good comment. Yes, that may not be everything one by one. Okay, we'll make that update. And then Lucy is asking, can you clarify optional to mean Rebecca won't be deprived of care if she declines some or all SDH questions? And Lucy, yes, of course, this is optional, so it's a she's volunteering to complete the screening questionnaire, and so it's not meant to be that she cannot receive services. So in that case, if she doesn't complete the screening questionnaire, of course, we don't want to get into the details of the workflow, but there could be another opportunity, even if she's not completed, but during her discussion with Dr. Sanchez, she may identify this as a need, and it can be incorporated in the notes as well as her care plan. So I think we have to keep, there's many, like I said, many options, many workflows. We just want to create a concise story, again, to focus on our use cases. So with that, let's move on to our updates to our use cases. So they look different than our last, when we last met, again, because we had looked at it at a high level as preconditions, postconditions, transactions, and payload. Now we've made some slight edits to incorporate assumptions specific to the transactions listed. So I'm going to walk through it. Again, we're talking about use case 1, which is about gathering social determinants of health data in conjunction with a patient encounter. We received recommendations to change the wording of the title. So again, we welcome feedback on that. So I'll walk through this, and then we'll pause for questions. So just, again, I know this is the first time for many of you seeing this, and I want to make sure it is clear, and that, of course, that you can readily react to it and inform our work. So this is regarding, now, again, we're stripping out the story, meaning that we're just going to focus on actual, as we say, the roles, the technical roles, and what's being asked, what's being shared, and so that's why it's labeled. So this use case element, which aligns with after transaction diagram figure 1, is we refer to it as solicited communication pattern, meaning that there is a formal request that goes out for information. So assumptions around this is that the practice determines, so we want to again clarify that there are ways to document or address if the individual does not want to answer or cannot answer the questionnaire or survey. So our assumption for this to work is that the practice determines appropriate questions to address patient consent to share social determinants of health information, and offers options to gather patient preferences regarding does not want to answer the survey, would prefer to answer the survey on paper, would prefer to discuss these questions with a care coordinator at the appointment, would prefer to discuss these questions with his or her provider at the appointment, and lastly, very important, needs assistance to translate or interpret the question. So we're making a really big assumption that the practice is addressing this. So as we're going through the story, this has been validated. The other assumption, of course, is patient demographic data is up to date. So when we jump into preconditions then, again, from a systems perspective, the requesting system or requester system, we are this is not an assumption, this must happen. The requester system is able to generate the social determinants of health screening questionnaire for the patient. The questionnaire is pre-populated with some available patient demographic information, date, medical record number, and a unique request ID number is assigned and included with the communication request. These, what you see here, are specific, we'll just say, data element components, data sets. And we'll talk about these more in detail as part of next week. So this is just a highlight that we will be talking about data set considerations. But for this particular use case, there needs to be a way that in this case, if it's the EHR acts as the requester system, it's able to generate that screening questionnaire and pre-populate it before it sends it to the other system. So the transaction itself is the EHR sends the social determinants of health screening questionnaire to the request recipient. In this case, as our story says, it's going to a mobile app because Rebecca has agreed to download the app and complete it. But again, it could go anywhere. It could go to a PHR, a portal, patient portal, or the kiosk. We initially had also looked at having it's displayed in a kiosk that's within the practice, and the patient completes it there. So again, there has to be data moving from the source, I guess, or the requesting system, the EHR, and sending it to another system for completion. The value add is that you have to have, to say this important, these data elements already specified in that, so you know what to do with that information when you get it back. So it can't just be a blank questionnaire. There has to be all these demographic identifiers listed so that the system then knows what to do when that message comes back. So the actual response is the request recipient, so again, our story is the mobile app, facilitates gathering SDH questionnaire information from the patient and sends it back to the requester system based on the original request received. So in this case, the mobile app receives that screening questionnaire, is able to render it, meaning display it on the phone, and allow Rebecca to answer the questions. So there has to be that capability, and then once it's completed, the app needs to know to send it back to the EHR. So we're not going to go into the how, but these are just the transactions. So just, again, probably too technical. Thank you, Lucy. All right. Post-conditions, user at the requester system reviews the response payload or message, which is really the completed questionnaire, then confirms the correct chart for attaching the document to the patient's record. So this recognizes that there needs to be some, probably manual, not assuming it could be electronic, but once it receives it, it needs to know based on that ID that it belongs to Rebecca. We also acknowledge here an alternative paper form, which is the operator at the requester system uploads. So in our stories, Samir, he receives the completed one. If he hands over Rebecca a paper questionnaire, he's able to scan it and then enters the unique request ID number. So there needs to be some way to track that this have a unique ID to be able to track that that form was completed by Rebecca. So the unique request ID number and MRN is used to file the populated social determinants of health questionnaire with the correct patient chart. The actors, so again, building up on the actors, because this is important as we go through the visual, and then I'm going to bounce back up to comments we received. The human actors in this case is the patient, which is Rebecca as part of our human actor, and the clinical staff member. The business actor is the practice itself. Again, they're just a business entity. This is where this transaction or use case occurs. The system actor, patient is interacting with a screening app, and of course the clinical staff member has the EHR, and then this is their role. So you see sort of that relationship I had mentioned in the previous slide. They then become, are differentiated between requester and request recipient. So I'm going to pause here before I jump and then onto our visual. And I see we have some questions. So before, or Lynette, I've not been tracking all of them. Is there one?
Certainly. I think you have seen Lucy John's comment regarding preconditions, that they should include the request ID number. And then Donna Rugg is saying, my question related to code assignment is after the patient has completed the questionnaire, because the codes are assigned based on the provider's documentation once the answers are known. And I believe she's referring to the comment in the document. And Donna, if you want...
Oh, yes, yes, I'm sorry, yeah.
Are you on?
This is Donna's comment right here. Yeah.
And Donna, something you wanted to add, I think, did I hear you?
Yes, this is Donna.
Okay.
I just wanted to, my question, I don't know if it's in the right place. And it may just be my confusion. It may be my confusion that it's not in the right place or not, but I was referring to the codes, whatever system is decided upon, ICD-10 or CPT or whatever, that would be assigned to illustrate the social determinants of health, but they can't assign the codes until the questionnaire has been completed and the provider documents that. So I didn't know if it was in the right place. That was my only comment.
Donna, this is Lisa. I was thinking there are standards around questionnaires and form responses, and the workflow that I was envisioning is that our work to decide what data elements have codes associated with them. In the case of the screening questions like this, we're going to have codes for the questions and codes for the answers. That the coding doesn't really have to happen after. It's really integrated in the whole design of the form, and in fact affects the standardized questions and answers that are being developed in the form themselves.
Okay, so as the patient completes the form, say electronically, then the, say, ICD-10 code is assigned based on the answer? Is that
yeah, we would already know. For example, if let's say the question is, how often do you go to bed hungry? And there's 7 answers that have different time ranges or something like that. You know, once a month, once a week, different things like that. Those codes would be known ahead of time. So as the form selection of that second answer, we already know the code that's associated with that answer. It's really the standardization is understanding how the relationship of the discrete codes go with the form and the structured answers that are designed.
Oh, I understand that. Thank you. That makes sense. I guess in my head, you can't assign a code based on a patient's documentation. The codes are based on provider or clinician's documentation. So that's where my head is. And maybe as we progress, that will shift. But that's why I was thinking that. That's why it was out of order.
And maybe you're clarifying, a difference between sort of when the form comes back versus data that's entered into the EHR.
As part of the billing or the the rating.
CMS actually, this is Annette Mossman at Ocean. CMS issued some guidance last summer that you've probably heard about, sort of urging people not to let that stand in the way of coding for social determinants. That the clarification is that the Z codes can be used without having to wait for the physician documentation.
My brain is thinking about ICD-10 guidelines because that's where I mostly spend my time, and it doesn't have to be the provider, but it generally is a clinician, not the patient. But I don't want to split hairs. I just was trying to follow the flow, and that may be some. I just want to make sure when you say code, there's lots of definitions for code. So I meant the coding system that whatever is determined would be the best solution, and I wasn't sure if it was in the right order, but it can be changed.
This is Al from ONC, Al Taylor from ONC. There's codes that, like a low-link code and a code set, an answer set that it represents the answers that patients derive. Now, the diagnosis, the ICD-10 code, may or may not officially have to be signed off and blessed by the provider, the clinician, when they sign their note and assign a Z code in addition to their regular clinical codes that they're assigning. So there's nothing that the provider is going to do to change the fact that answer code for, 3 days out of 7, I go to bed hungry, that code is going to be the same whether the patient said it, because the patient always is the one who says it, really. The patient says it, and then the provider says, did you say this? And they say yes. And so that part of the code is going to stay, whether they answer it on a tablet, a piece of paper, or the doctor asks it.
Yes, you're correct. The answer is the answer. And you're right. It may be later the doctor sign off on it, and that may be I'm just being too detailed. So thank you for the explanation. That makes sense.
Thank you, Donna. No, wonderful. And thank you, everyone, for chiming in. I do want to recognize we've got some other comments here. Henry has noted that we need to allow for the problem of patient matching. Of course, if the patient is using a third-party app, the patient's app will not know what the MRN means. So I think that's a way we included in the assumption. I think that's another, we can go down another path for that, but we want to assume that, again, that this will be a streamlined process. But thank you, Henry. And Sarah, of course, is also acknowledging we don't want to lose track of codes. Now I'm losing it. From the questions themselves, of course, low-link and all. So, yeah, true. We're coding for these questions coding both at the question and answer. Larry would like if you can share the CMS guidance to the group, so please send it to us, or if those that have it, if you can include it in the chat feature for Larry. And Lucy has some comments. We should say, go to sleep hungry. Great. So Lucy, keep that when we get to the housing domain of how we should be labeling or defining these concepts.
Okay.
And here we are. Thank you. Yes, that's a great point. Okay. Any other questions or thoughts from the collaborative before I jump on to our next use case? I consent. Thank you, Amber. All right. Okay. So I'm not to spend too much time on the visual, but this is, so I'm just showing a bigger here. So all those pieces are just highlighted here. We have what we call these actor transaction diagrams, and this is for use case number 1, solicited communication. So we have a very simple communication request going from one system to another, and then a response back. So pretty simple, we think, but not so really. But the transactions are clear. Now let's move on to our second use case. So again, this is around documenting and tracking SDH-related interventions to completion. So we're noting that, in some cases we would want to have some way to close a loop if there's a referral, but we also want to be able to, determine, or if we're developing a care plan or an action plan, that the actions identified are completed, right? So even if they're not, because some of these actions, as our patient story indicates, are actions that the patient is responsible for. So there needs to be a way to acknowledge that action and then close it in the system. So here we are with solicited. So in this case, again, we're calling it a solicited service request pattern. And I'll have, again, I want to acknowledge Lisa Nelson's work on all this, because she helped organize this based on the patient story. So, and labeling. So, and Lisa's on the line, of course, and can address some questions. So I know Helene Sweet had submitted ones, and I think she's driving right now, but I do want to acknowledge an addition she had. So she wanted us, she didn't know where to put it, but she did acknowledge that we need to have some assumption that the clinical staff works with the patient to understand their preferences about an order before placing the order. So it would be, for example, if they have preferred suppliers, if they're looking for a medication, they want one with a lower cost. So some way of recognizing that. I know there could be transactions around this as well. There could be some clinical decision support, but we've streamlined this here as, assuming that that's been done. Here, the other assumption is that the order placer automatically assigns a unique identifier to the service request, and the order filler, the one who receives that order, is able to receive and process the order request from the order placer. So these are high-level assumptions. And let's move on to preconditions. The preconditions.
Can I make a comment about the title of this set of transactions? If you could go back to the title. Yes, solicited service request pattern. I think we would all agree that everything going on in this section of this project is where the healthcare system fails constantly at one or another point. So to me, this is incredibly important and really the most important thing that this project might actually accomplish. So I would like to suggest that the title of this figure be amended to say solicited service request pattern to completion. Insert to completion, because if the pattern is not completed, patients get lost, referrals get lost, documents get lost. This is where everything bad happens that we all know so much about. So I was wondering whether the concept or the idea that we're talking about a pattern that needs to be completed and not just get into constant feedback loops or dead ends or whatever. Thank you.
Thank you, Lucy. No, that's a great comment. And let's walk through this and figure out, and Lisa, chime in. I know we have a notice transaction here that there is a way to documenting that it has been filled, and I know that was Helen's also, or we had, unless I saw it from another one where it's not just it's just not the activity that it was filled. It is really, were they compliant? One thing is to fill it, and the other piece is to be compliant in the case of medications.
Yeah, I think there's the words "to completion" are in the title, and we just need to add it to the pattern as well. I agree that "to completion" is a good point to reinforce.
Thanks, Lisa.
All right. Okay, so I'm just going to walk through the preconditions. So the clinical system has documented, in this case, or the EHR, has documented assessment information, health concerns, goals, and planned interventions or performed referrals. So we're saying all these activities would have happened already, and the clinical system then takes on the role as an order placer system and assigns and includes the unique service request ID in the order. The transaction then is around a service request. The order information, whether it be a referral, a planned intervention, or order activity, again, we want to say that payload can be any of those or all of them together, and is sent from the order placer to the order filler, which could be the system that is used by the person, organization to complete the request, such as a case management system, a pharmacy system, and mobile app. So just as a refresher for those, this transaction is based on the patient's story when they determine, again, engaging both the doctor and the patient, engaging together and putting together their care plan, their action plan. They determine that she agrees that she needs support both for her health concerns and her social needs. And they determine that there is or the doctor says, we are going to order a new prescription for you. So can place the order directly from the EHR, and also can place the order for an in-home site visit for her asthma condition. So, or the asthma, for her to figure out whether there's mold in the home. So in our case, we're assuming that there is a connection. There's an ability for the EHR to interact both with the pharmacy system, and assuming for the in-home site visit system or a case management system. So this is the case where they are able to interact and respond to each other's requests. So that's the first transaction, the service request. Of course, the message content would be the actual, what information is needed to fill the order. And then the post condition is that the order placer system has a receipt of the order request from the order filler. Order filler has acknowledged receipt of the request and supplied an ID associated with the order in its system. So lots of information.
What about when the order filler declines to fill this order? Does that need to be in this chart somewhere?
We do have it.
Okay.
We have it as an alternative flow. Lucy, you're ahead.
Oh, there we go. I'm sorry.
Okay. Yep. So alternative flows are, again, recognizing that the order filler may reject this order request. It could be either they don't have what is being ordered, or they don't. It could also be, for example, if there's an in-home site visit, maybe they need, recognizing too, they need to have another level authorization, or they need to confirm whether Rebecca is eligible for an in-home site visit. So there could be many reasons around it, but we want to recognize that that could be part of the flow. So in that case, the order placer then needs to send a new request. And lastly, there could either be a flow where you can have a request sent, an ordering request, but the receiving system does not have a mechanism to send back, to respond back. So we know there could be, again, this would be a different type of transaction, but they can acknowledge receipt of the order request manually, either by fax, phone call, or email. And of course, acknowledging this was one of Elaine's comments, that there are multiple rules. You know, there could be many reasons an order could be rejected. So just wanted us to highlight them there. Any thoughts or questions? I see lots here. I don't know if they're all being addressed. Or Lynette, I've not been following.
Yes, I can. Give me just a second here. I am furiously copy pasting. Okay. There was some discussion a few minutes ago, starting with Larry Simon and Carla Nelson and Kim Grayor, I believe. I hope I did not butcher your last name, Kim. Larry's comment was on one other thought on providers regarding I-10 billing. One institution in my market is trying to figure out how to capture these Z codes using nurse documentation, but not put them on the bill. The clinical codes entered by the providers would be used for billing, but the Z code could still be housed in the system's database for mining or research. And Carla responded saying some EHRs have role-based access and it would be difficult to add a Z code somewhere. May depend on organization, EHR, and state laws about scope of practice. And Larry responded, exactly. It's tricky because two of the main roles for these codes are to A, identify high-risk patients who need access to case managers and social services, and B, research. They are not necessarily valuable on the ultimate bill or claim, and if the patient is very sick, there might not be space on the bill to use the Z codes. All the other codes may be needed to achieve the proper DRG, but we still need a way to capture these codes for tracking, research, and social interventions.
Wonderful.
And then Matt is asking if there's anybody familiar, Matt Bishop is asking if there's anybody familiar with research on the percentage of referrals where the referral loop is closed, saying his impression is that most healthcare practices don't track this metric as a matter of practice. So if any of you out here in phone land happen to know of any of that type of research, please include it in the chat or email it to gravityproject@emiadvisors.net and we can distribute.
Is there anyone on the call from 360X?
No, thank you for bringing that up, Lucy. Yes, I think we are very familiar with the 360X project, and I know Holly Miller is very active, so she's been leading a lot of that effort, and if we do need metrics, someone just put us on hold.
This is lovely music, but I'm going to have to mute it. Hang on. All right, there we go.
Thank you. Why we keep everyone on mute sometimes. No, yes, for those not familiar, Holly Miller is from Edelweiss. She's been doing a lot of work and leading a lot of national efforts and testing around the 360X standard. And a lot of these concepts, so Lisa chime in as well. Lisa's included the request ID, that's because that is a lot of what comes from that standard, the ability to track by issuing an ID. So I think she does have metrics. They've been doing a lot of testing, and I know she's had pilots as well, so we can follow up with that.
Thank you.
Okay, so I know moving along, so let's, this one, it brings up the topic again, even about the closed loop referral, but, and again, recognizing Elaine's comments here. So here is a service request response where it actually comes back that it's been completed, is communicated back. So one is, this is the second transaction as part of this use case, transaction 4, it's coming back saying the order filler is able to receive it, process it, complete it, and send a message back. So Elaine also brought, very much what you all said earlier, that even if we talk about, an order like a pharmacy, a drug, and clinicians have noted that they are, so just her point was, clinicians are more interested about when the order is actually received and being used by the patient versus when the order has been filled and might be still sitting in pharmacy or not delivered to the home yet. So Lisa, actually, I had that point for you. Is that something right now, do we have another ID? So one is in the response back, is there an opportunity to document both that it's been received and filled and then completed, meaning that it's picked up or delivered to the patient? Oh, is Lisa on mute?
No, I think I'm not. There are many workflow steps that are possible to document from all the way from the intention of taking the medication to the ordering of the supply to the filling of the supply, and I'm thinking that there's a final state that I'm not sure. I have to figure out what the semantics is for representing that it got picked up, separate from the notion that the pharmacy filled it. But I will check on that. Yep.
Thank you. That's a great, and this is, again, too, the same with the in-home site visit. One thing is that it's accepted, whether or not, it's been scheduled is another thing, but you can schedule something, it could be canceled, and then it's never completed either.
Lisa, a wrinkle that maybe you want to think about is that some orders may be placed into mail order and not picked up. The image of going to a pharmacy or sending someone to a pharmacy. So sometimes, in fact, all the pharmacy benefit managers would prefer that you order rather than pick up anywhere.
Right. Yeah.
Okay.
I mean, even, we get over that last part, and then it's like, okay, but still did the patient actually take it?
Well, that goes without saying. Yeah. But I was just thinking about the verb to pick up. May not apply to a lot of transactions involving prescriptions in particular.
Interesting. Yeah. The direction of that last step. I would think about that.
Thank you. And I'm just looking at some comments here as well. I think it's also us recognizing that there's only so much the systems can do. So these are things too about compliance or, whether something was scheduled and completed, that there is some action itself, from the individual is accountable for certain things as well as the system. So these are also, I think these are really great points for us to consider as we put together risks, issues, and obstacles as part of our use case, because these are things that are inherent in our health system, and we can try to put the technologies and the systems in place, but there are still going to be these nuances or issues that come up that we still need to acknowledge and be aware of. So I know we can go down a rabbit hole that way, but it really helps us, think through again, but not lose. I think Lucy has been. Don't lose sight of this because these are the main issues we're experiencing right now, and where there is great opportunity for innovation. All right, so I know we've got 8 minutes left. I'm going to move us on to our third use case because that is the most, it's not complex, but it has the ability where it introduces three actors versus having 2-actor systems. You have a 3-actor system. So I'm moving on, and again, these will be made available for you to review in detail in the visual. So the last one, for our last 8 minutes here, we had developed this use case to acknowledge these, what we say, the upstream and downstream activities. So they're really where the data is now being used, right? So because it's documented in a standard coded way, there's ability for it to be aggregated, readily aggregated, real time, and then used. And in our case, we talked about scenarios specific around population health managed, so the data could be used by the practice and being able to track, how many, what social needs were documented and related referrals and whether or not those were completed. So again, to our talk about whether as we have an order out and if we think of an order from a referral, was that referral completed, right? So there's the ability to aggregate data can support this work. The other one was around quality reporting, recognizing that there's much work going on right now and the ability to aggregate the data for quality reporting. And then lastly, of course, risk adjustment and risk stratification. So we didn't, again, lots of assumptions here, and we don't have these as part of the patient story. So I want to recognize these are things we didn't include because we wanted the patient story to be around Rebecca and her life trajectory, right? So we can continue moving on with Rebecca's story if we'd like. But, we have a stop. But in this case, it's what do they do? What does Dr. Sanchez's practice do with the data now that they have it documented in a coded way? So when we talk about the use cases, Lisa's done a phenomenal, and she actually, I do want to acknowledge, Lisa's identified many use case elements and actor transaction diagrams. For our purpose, again, my job is to get you to food insecurity by July 18th. I want to just identify those that can, again, value add and really can explain the opportunities in these transactions. So we'll start with the first one, which is unsolicited communication. So the other ones were solicited. There was an ask, request, and this one, it's not. So the assumptions is here that the information source has the capability to aggregate social determinants of health encounter data and share that aggregated data with other systems. So, and in this case, the information recipient is able to process and use the aggregated data. So if we're talking about population health management or quality reporting where it's going to the state has to, again, I'm hearing some background noise. Sorry if you're not speaking. Please keep yourselves on mute. Thanks. Okay. So in this case, the EHR serves as that information source. So it's one that is documenting the social determinants of health data and then can aggregate it. Again, recognizing EHRs, most of them have that capability right now. And then this transaction is really around them being able to push that data out to, in this, such as if it's for quality reporting, to the state Medicaid agency or any other system where quality reports can be submitted. So this is a very straight, the information source serves as the data aggregator and then sends the data out. Nothing is coming back. So really important here, it's only one transaction, it's just pushing data out. And there's nothing coming back saying they received it or not, so it's just the ability to aggregate. The second one, which Lisa nicely calls the unsolicited communication pattern or the SMART recipient, you go through the same process, and I'm going to show it more from a visual, again, given our time. In this case, the information source is not the data aggregator. So they're still sending the data, but they're sending it without aggregation. So I would defer to Lisa to explain how that would look, but in this case, the data, it could be multiple, like so in case it could be a state Medicaid agency may ask for only Rebecca's data. So it's not aggregated data. The EHR, Dr. Sanchez's practice may just send Rebecca's data as a file on its own, but then the system, receiving system in this case, could aggregate it for multiple members or beneficiaries.
The most standard thing we have for this right now, Evelyn, is what's called a quality report document, or QRDA Cat 1. It's a patient-level document where certain data elements that are needed for quality measures, for example, or downstream use that way, are sort of plucked out of the EHR and sent. We also have examples where the information source system just focuses on making good clinical documentation, like an encounter summary, and then the receiving system is smart enough to know how to pull data elements out of those encounter summaries and use that data for other purposes.
Thank you, Lisa. And I'm going to end quickly on the last one, which is important because I think this is also realistic as we look at too, as we have many middlemen or we had talked about calling it middle system, where it could be the data is moving out from one system, but you have a middle system that takes on that role of aggregation, right? So we see that, it could be an integrated, you could have a data analytics platform that pulls the data out of the EHR and is able to aggregate it and share it with somebody else in a standard format. So lots of scenarios here, and we could also have the same, we had one acknowledged from other of our participants that this figure 5 can also apply for the order filler, because you can also have a middle system serve as the one to receive an order and then send it out to another system. So some of these could be, we talk about clearinghouses for claims data, HIEs, CIEs also play that role. So I'll stop there. I know we have 1 minute. Any questions or thoughts? I know for homework, the homework is to review this, and I'm taking up Lynette's time, but it is really to remind everyone that we do have this posted already. We welcome your feedback, and we'll be consolidating throughout the next coming weeks. Any last minute questions, or Lynette, is any of these, I see there's conversations back and forth, so I want to make sure there's anything for me to address.
I think some of these we may need to address offline, and thank you, Donna and Amber, for sending us ICD-10 information. We will post that on the wiki, and we will include links to them when we send out our follow-up email. And I think with that, I think we're good.
Good. All right. Any other last-minute questions? Or we're at the top of the hour? Sounds like. Okay.
Oh, and one more question to you all. There was a question if there are any links to the Anderson presentation. So if anyone has access to that presentation, I'm not quite sure what anyone is referring to. What that's referring to.
Lynette,
but if,
I think
yes.
somebody called me Lisa Anderson instead of Lisa Nelson. I believe I think they're talking about how certain code systems are aligned with certain uses. It was probably data elements first session or maybe data elements second session.
Okay.
Second yeah, it's the second session. Yep.
Okay, and that is on our past meetings. Yes, that's in our past meeting materials. And I can verify when it was, I believe. Please hold. It was,
it's
sorry
week
everyone.
2.
Week 2, which would have been May 16th, I believe. No, yes, May 16th.
No, it would have been the second week. So we kicked off May 2nd, so it would have been May 9th.
Okay, sorry.
May 9th. And just a reminder, everyone, in that presentation, we also have on our Confluence, Lisa and Linda put together fabulous tutorials about each coding system. So if you want to become more familiar about each one and how it's used, we have that recorded as well. Great. Well, thank you.
You're really good at hitting stats here.
No, thank you, everyone. I appreciate it. All right, we're only 1 minute past the hour, so thank you so much. Yes. Hope you can all join again next week, and please comment, and we'll talk to everyone next week. Thank you so much. Have a wonderful weekend.
Thank you all.
Thanks.
Thanks.